The exciting news of the reality study is that if right from the beginning of their treatment, we added on a combination of these anti-microbial drugs, would be able to reduce the mortality.
The reality trial set out to help people like Moses, recently arrived at a hospital in Malawi after months of terrible headaches. He tested HIV positive with a CD4 count of only 11, showing his immune system has been almost wiped out by HIV. He also has cryptococcal meningitis. It's a common story.
1 in 4 people who start anti-retroviral therapy in Africa start late. They start when their CD4s are already below 100 cells.
We're still getting teenagers quite ill, and people in the early 20s quite ill, with the more severe forms of TB, pneumonia, and blood infections.
This is the group where HIV-related deaths mostly occur.
Along with treatment for meningitis, Moses is starting anti-retroviral therapy, or ART, the drug combination that targets HIV. But his immune system will take months to recover, putting him in danger from opportunistic infections. Of those who, like Moses, start ART with a low CD4, around 1 in 10 die during the first 6 months on treatment. So, can we do anything to help them through this period? To answer this, the reality trial randomized more than 1,800 patients in 4 African countries to test strategies for those starting ART with a CD4 below 100. All patients already get the antibiotic cotrimoxazole to protect against opportunistic infections. Reality tested the use of an additional package of easily available antimicrobial medicines. This enhanced prophylaxis package included a single dose of albendazole, the antibiotic azithromycin, 12 weeks of fluconazole, and isoniazid pyridoxine against TB. There was a clear benefit.
The results of the trial were significant. In the standard prophylaxis group, who just received cotrimoxazole, over 12% of patients died by 6 months. In the group who received the enhanced prophylaxis package, the death rate was less than 9% at 6 months. Another way of putting this is to say that for patients with low CD4 counts who are starting anti-HIV treatment, for every 100 that you gave this enhanced prophylaxis, you would save between 3 and 4 lives.
That represents a 27% reduction in mortality in the group of African patients with the most HIV-related deaths. Hospitalizations also reduced. There were fewer cases of TB, cryptococcal meningitis, and candidiasis. While results showed no impact on bacterial infections, doctors believe this was because these infections were often undetected.
For the bacterial infections, they are difficult to diagnose in the settings where we were in African hospitals. However, there were less early unexplained deaths in the enhanced prophylaxis group, and we think that was due to the azithromycin antibiotic, which was part of the package.
Researchers are recommending the package be kept intact as used in the trial. They found no increased side effects, and viral load was suppressed just as fast. To avoid significantly increasing the pill burden, the trial used a new pill combining the anti-TB medicine isoniazid and cotrimoxazole. The antimicrobial package is cost-effective, and it's easy to use in the crowded health centres where most HIV is now treated. It doesn't require extensive lab testing. Patients can start after a clinical check to rule out TB or meningitis.
We already have a working system giving out ART, and that's very successful. we're already giving out cotrimoxazole. If the money was there to get these drugs as a package, the systems are in place that patients will be given the drugs.
CD4 tests at baseline, however, would still be necessary, as shown by the experience of Tom and Maria. Both were patients who volunteered for the trial. Before he suddenly fell ill, Tom had no idea he was in danger.
Because last time I was in the hospital was 1958. I was never sick. It was sudden. Within 10 days, I was so bad.
In hospital, Tom tested HIV positive with a low CD4 count. His wife Maria also tested HIV positive, also with a CD4 below 100, but she had no symptoms. This was common. The average CD4 count was only 36 cells, but half of the patients had no or only mild symptoms. So, doing a baseline CD4 test is the only way of identifying many like Maria who would benefit from the extra prophylaxis.
The current WHO recommendations of using viral load for monitoring of anti-retroviral therapy does not mean that CD4 test has become totally useless and unnecessary. Clinical assessment does not always give us an indication of those most at risk of dying.
The other important question Reality sought to answer is why so many people still seek treatment late.
They aren't themselves necessarily seeing it as late. I think that's probably the key message. They're turning up when it makes sense to them, rather than thinking, oh, I'm really late to get treatment now.
Social science research showed most Reality participants believe the right time to seek treatment is when you get sick. The research found many still frightened of treatment, fearful of side effects, of being identified, and of HIV itself.
HIV is the killer.
Everyone knows HIV kills. There's much less knowledge about the massive benefits of early treatment, around which current HIV strategy is built. It suggests that health campaign messages need to be refocused.
The newest message, which is really getting onto treatment as soon as possible and test and treat, is still very kind of nascent within the community. For example, the fact that treatment has a kind of a sense of fear around it demonstrates that message certainly isn't getting through.
It's a question of informing the community, passing on the good news that those who start early do extremely well.